Hi, welcome to our channel of IGNOU audiobooks, Indira Gandhi National Open University, School of Health Sciences, SOHS. Postgraduate Diploma in Geriatric Medicine, PGDGM, revised. MME 105 Clinical Geriatrics-I. Block-1 Different Phase of Clinical Geriatrics. Unit-2 Comprehensive Geriatric Assessment, CGA. 2.0 Objectives. After reading this unit, you should be able to define what is CGA, why and when it is needed. Enumerate the components of CGA and the roles of various team members. Describe and appropriately use the various assessment tools. List the problems, devise goal-directed treatment plan and follow-up. 2.1 Introduction. Older patients are known to have multiple health conditions. The traditional disease-oriented evaluation and treatment will be deficient in complete assessment and in helping recovery from the illness of the elderly patients. Almost all acute and chronic illnesses can reduce functioning, impaired cognition, impaired special senses, problems with gait and mobility, poor health habits, poor nutrition, polypharmacy, incontinence, psychosocial factors are easily overlooked as the contributors of functional decline. Well-designed, multidimensional approach helps to deal with these complex problems, prioritizing the treatment according to the needs of the patient in a systematic manner. Though these principles of assessment are generally applicable to all age groups, multimorbidity, age-related vulnerability to unique problems and social and financial insecurity makes the geriatric population the greatest beneficiary of the multidimensional interdisciplinary approach. This helps to identify treatable causes that contributed to the functional decline in addressing these issues will have a significant improvement in their functional status. Hence, comprehensive geriatric assessment helps in continuity of care by the primary care physicians, and there is evidence to support the improvement in health-related quality of life. The principles of CGA has also been incorporated in some specialty treatment like oncology, emergency care, post-discharge treatment plan, orthopedic care and preoperative assessment to make the physicians aware of and to anticipate the problems, devise appropriate therapy and to avoid complications. 2.2 Principles and indications of CGA. Let us first understand what is CGA. CGA is defined as a multidisciplinary diagnostic and treatment process that identifies medical, psychosocial and functional capacities of an older adult to develop a coordinated plan to maximize overall health with aging. It is based on the premise that a systematic evaluation of frail older persons by a team of health professionals may identify a variety of treatable health problems and lead to better outcomes. It is a multidimensional holistic assessment of geriatric patients consisting of a number of steps. It includes screening. Done. Then the screening is done for assessment of nutrition, cognition, continence and functional ability, and medications are reviewed and optimized. Social, environmental, and spiritual assessments are also carried out in the appropriate time. Based on the results of this preliminary screening of health status, detailed evaluation of selected problems by appropriate persons is planned and solutions formulated. It is a long and detailed workup and requiring sufficient time to complete. It may require more than one sitting to complete the process. At the end, the interested family members and multidisciplinary team members can discuss the recoverable issues of the person and can plan long and short-term action plan. CGA allows reviewing the progress and reassessing an intervention modification of the original plan at intervals as per requirement. Indication for CGA. CGA is useful in following conditions. 1. Older persons aged more than 75 years old when first seen. 2. When the elderly is having one or more frailty syndrome or functional disabilities. Falls, cognitive decline, depression, reduced mobility and increasing incontinence even when reversible cause is evident. 3. At the time of admission and discharge from the hospital for various reasons like pneumonia, fracture, pressure sores etc. And if high healthcare utilization is anticipated. 4. When admitted for treatment of conditions like hip fracture, transcatheter aortic valve replacement, renal replacement therapy, cancer chemotherapy etc. 5. Before admission to old age homes for advanced care planning. 6. for research purpose in community dwelling elders and to measure the effect of intervention. The indications of CGA have been enumerated in Box 2.1. Indications of CGA. Advanced age more than 75 years. When experiencing recent onset geriatric syndromes. Before treatment hip replacement, TVAR, renal replacement therapy, cancer. Chemotherapy. Recurrent inpatient admissions. Change of living arrangement. Research purpose. CGA is unlikely to be beneficial in patients with terminal illness, severe dementia, and having complete functional dependence. 2.3 Components of CGA. Case Scenario 1. A 78-year-old female, with history of diabetes of 20 years duration. Recently she is widowed and has not come for her regular quarterly checkup. She was brought to your clinic by her daughter as her mother called her that morning with a severe back ache after she slipped in the bathroom and sat on the floor. Do you think this patient will be benefited by CGA, and if so, where will you do? CGA can be done at patient's home, doctor's clinic, daycare center, old age home, community place or hospitals. It is teamwork where interview techniques and process is important rather than the place. It should also be noted that all the components cannot be and need not be assessed on the same sitting. For example, when the patient is admitted in the emergency room, the components which may have an impact on patient's clinical course like sensory system, cognition, nutrition, activity level prior to admission should be quickly screened, and availability of any advance directives should be focused when the same patient is likely to be discharged to his home. Environmental assessment, social assessment should also be focused during the discharge. CGA. Physical assessment, general and systemic examination depending on patient's symptoms, nutritional assessment, review of medications and screening for polypharmacy. Screening for specific geriatric syndromes. Functional assessment, screening for visual and hearing impairment. Activities of daily living. Screening for gait and balance problems. Screening for memory and affective disorders. Other specific geriatric symptoms: incontinence, urinary. Office level CGA is suitable. It needs coordination between doctors, trained nurses, physiotherapists and community level workers. The basic details of the patient, including the socio-economic status, can be collected by the basic health workers, non-medical clerical grade persons, filling up the pre-structured questionnaire by patients, listing out of patient symptoms and relevant past medical history as per the patient. Records can be done by trained nurses. Similarly, listing out all the medications, prescription, non-prescription, over-the-counter medications, non-allopathic medicines taken by a patient can be made by the trained nurse after verifying them. The primary care physician can do symptom-related systemic examination, disease-specific examination for complications and focused examination depending upon the new functional disability. This includes the screening for geriatric syndromes as mentioned above. At the end of the screening session, further necessary investigations and specialist consultations are planned and executed. The recommendations for continuing medical care, including physiotherapy, are also planned and will be carried out. A model of such task assignment is depicted in Box 2.2. Periodic review of the patient by the team for evaluating the result and for making necessary changes in the plan should also be carried out. Basic health workers, pre-visit questionnaire, telephonic interviews, demography, socioeconomic details. Trained nurses, nursing assistant symptom list. Details of past medical problems, complete medication list. Primary care physician systemic examination, search of complications of pre-existing disease. Screening for geriatric syndromes. Functional assessment. Specialist evaluation and treatment of specific problem. Therapists, physio, occupational, addressing specific problem. Box 2.2 model for assigning tasks for various team members. Our patient is presenting with recent functional decline. She definitely needs CGA. It can be done as an outpatient setting after giving priority to the assessment and treatment of her painful condition. She might need more than one visit to complete them. 2.4 Physical assessment. Let us learn more about the various components of physical assessment in the following subsections. 2.4.1 Physical examination. Old people get tired or bored due to the long process of interviews and physical examination. So, this can be divided into more than one session. Many a time due to mobility limitation, exertion or deformed posture, kyphosis, scoliosis, bone deformities, or severe heart failure, adaptive physical examination need to be performed. Dementia, delirium, psychiatric illness or uncooperative attitude is common, so ideal consent or refusal can be decided with the help of relative or other caregivers. Case Scenario 2. A 85-year-old man, a known case of hypertension on regular follow-up, reports that he has noticed difficulty in writing letters for the past 3 months. He has also curtailed his morning walks as he experienced sudden freezing episodes and 2 episodes of near fall. In past 6 months, when examined, he has features of Parkinson's disease and fear of fall. Some of the observations which can help the line of focus later can be done while the patient enters the room, such as observing the need for assistance for movement and in case of usage of assistive device, whether it is correctly used. Gait of the patient, any evidence of pain and swelling in the joints which makes the movement difficult. Presence of edema of the extremities. Choice of dressing which can suggest difficulty in getting dressed and the fitting of the dress. Most of the Indian old women will be attired in sari. And if they come to the examination room wearing nighties, it is a clue to their functional disability. General conversation will reveal the mood of the patient, hearing and visual ability, and an idea about the cognition. There are no scales for doing traditional examinations of the patient. But with the knowledge of the patient's coexisting diseases, the examiner should also look for the complications. For e.g. in a chronic diabetic, neuropathy, nephropathy etc. should be sought for. All the patients should also be tested for BP fall in different positions. Those suspected to have orthostatic hypotension should have BP checked in lying down and standing BP at 1 and 3 minutes. Similarly, nutritional screening and screening for polypharmacy can be made the integral part of physical examination. 2.4.2 Nutritional assessment. Older people are vulnerable to develop malnutrition. This is also multifactorial in nature. Age-associated changes like decreased sense of taste and smell, loss of dentures, the effect of chronic health conditions and the drugs taken for it, poor functional status, psychoaffective disorders, and poor socioeconomic conditions can all contribute to development of malnutrition in elderly. History of poor appetite, decreased food intake, indigestion, prolonged diarrhea, recent acute illness and hospitalization, recent surgery are some of the clues from history. The general examination may show the presence of anemia, edema, and systemic examination will help to find out the underlying medical condition. Screening tool Mini Nutritional Assessment, MNA. Scores from 0 to 2 are given for a set of 5 questions. They are decline in food intake, weight loss, mobility issues, psychological stress, and other neuropsychological problems. BMI is calculated and score from 0 to 3 given for that also. Finally, calf circumference is measured and total score out of 14 is calculated. From this, categorization into normal, at risk of malnutrition and malnutrition are made. 2.4.3 Medication Review. Due to multiple comorbidities and medications, review of medications is an important component of CGA. Many evidence-based therapies useful in the long term may not be useful or may even be harmful in elderly population. This review many times helps in reducing the pill burden, cost and side effects. Many preventive drugs for long-term complications can be removed after looking at the lifespan of the individual. Following steps can be used for reviewing medications. 1. Take full medication history including over-the-counter drugs, illicit drug use, herbal preparation etc. Review the prescriptions used by the patient for procuring drugs. 2. Follow brown bag technique, which means requesting the patient to bring all the drugs they are using and verify that there are no duplications, errors etc. Take the person's opinion about each drug, like swallowing difficulty for big capsule or tablets, belief about effect or side effect etc. 3. Review the drug list for pharmacological interaction or possible side effects. 4. Review each medication, assess its need at present and also assess any difficulty in its use, i.e. swallowing, cost, availability, mode of use, smell, side effects etc. 5. List and prioritize the drug list with the help of a prescribing specialist. If needed, then the person should be explained about the mandatory drugs clearly. Supplementary drugs can be suggested after the mandatory drugs with discussion with patient or relatives. Case Scenario 3. You are approached by the son of a patient when a 65-year-old male who recently got discharged from hospital after severe COVID illness. They request your consultation as his father, who was previously independently doing his activities, has become bedbound and incontinent. This case is an example of an acute illness causing functional decline in elderly. The patient in case 2 is an example of functional decline occurring subacutely and by himself, the patient reporting inability to do particular activity which he has been doing previously. The causes may be multifactorial. These patients need physical assessment, as discussed, and also need functional assessment. 2.5 Functional assessment. Elderly have different coping strategies for different functional losses like sensory loss, hearing loss, visual loss, or loss of function of a limb. Any acute illness can also lead to functional loss. Functional assessment should be done with the following questions in mind. 1. What can and what does a person do actually? 2. Any recent change in person's above capabilities? Finding the answers to these questions and in-depth analysis of the causes of the change will give a clear idea about the functional status of patients and what can be done. Further, the following screening are done in functional assessment. Visual and hearing ability. Ability to carry out basic and instrumental activities of daily living. Gait and balance problems. Screening for memory and affective disorders. 2.5.1 Visual and hearing ability screening. Vision screening. The standard method of screening is by Snellen eye chart. Screening for hearing impairment is done by a whispered voice test, where 3 to 6 random words, numbers, words or letters, at a set distance, 6, 8, 12, 24 inches, from a person's ear, and then asking the patient to repeat the words. The examiner should stand behind the patient with the patient covering the ear one by one. If the patient is not able to repeat half the whispered words, the screening is positive and the patient needs detailed evaluation and management. 2.5.2 Screening for activities of daily living. CATS ADL scale. CATS index is an easy choice for measuring functional ability. It takes into account about performing 6 core functions, namely feeding, bathing, dressing, transferring, toileting, and exercising control over bladder, continence. It gives a baseline score and can be reassessed. It has components of self-report, professional assessment, and family opinion. The informant rates the subject's competence in each area according to a set of 4 descriptions of different competence levels. Scores range from 0 to 3, where higher scores indicate greater independence. Lawton's Instrumental Activities of Daily Living, IADL, Scale, Complex. Activities of Daily Living Assessment. Lawton's Instrumental Activities of Daily Living, IADL, Scale was developed to assess more complex activities, termed instrumental activities of daily living, necessary for functioning in community settings, e.g., shopping, cooking, managing finances. The capacity to handle these complex functions normally is lost before basic activities of daily living, e.g., eating, bathing, toileting, which are measured by ADL scales. Therefore, assessing IADLS may identify incipient decline in older adults or other individuals who are otherwise capable and healthy. The Lawton IADL contains 8 items that are rated with a summary score from 0, low functioning, to 8, high functioning. This scale can be administered through an interview or by a written questionnaire. The patient or a caregiver who is familiar with the patient can provide the answers. The scale is ideal for community-dwelling older adults, as well as those who have been admitted to a hospital, short-term skilled nursing facility, or rehabilitation facility. 2.5.3 Screening for gait and balance problems. Imbalance and falls are very common problems of elderly, 10% to 15%. Muscular weakness also contributes to change of gait and is important to prevent fall. These also help in diagnosis of systemic illness. For normal balance and gait proprioceptive inputs, writing reflexes, vision, sensory inputs, central processing, musculoskeletal coordination, and vestibular system are important. These functions may deteriorate with aging due to systemic diseases and many times because of regular medication. The importance of diagnosing possible gait and balance problems are very important to prevent fall. It also help in early diagnosis of many systematic diseases. 1. It will enable control of painful conditions before referring to physiotherapy for better participation of patients. 2. It will enable diagnosing early stages of neurological conditions like Parkinson's disease or motor neuron disease so that specialist referral can be done. The steps of this process are: history, patient's version of functional impairment, e.g., difficulty in dressing, difficulty in climbing stairs. Do they experience any difficulty in walking? Change in walking pattern, short steps, tendency to fall backwards. Walking with feet kept either wide apart or close together, unequal weight. Bearing, uncoordinated walking, sensory disturbances in feet. Restriction of activities because of this. Ability to get up from chair, bed, walking upstairs. Any history of fall, if so how many times in the past 6 months and the events occurring before, during and after falls. Recurrent falls is defined as more than 2 falls in last 6-month period. Simple tests. Observe the patient's gait. Table 2.1 Some of the common gait disorders. Table 2.1 Common gait disorders. Foot drop, peripheral neuropathy, previous CVA, narrow base, freezing, loss of arm swing, Parkinsonism. Antalgic gait, less time spent on stance, pain in joints, limb, weakness of one leg. Circumduction of one leg, upper motor neuron weakness. Broad-based, ataxic gait, cerebellar weakness, multisystem atrophy. The screening tests are 5 times chair raise test, 5x SST, and timed up and go test. Tug. Those who have problems in performing this test are subjected to short physical performance battery test, SPPB, for confirmation and further referral. Chair raise test. The 5 times sit to stand test, 5x sit to stand test, commonly abbreviated as 5x SST. The 5x SST scoring is based on the amount of time, to the nearest decimal in seconds, a patient is able to transfer from a seated to a standing position and back to sitting 5 times. The lesser the time taken to complete the test, the better the outcome of the test. A time period of more than 14 seconds to complete the test is considered abnormal, and further detailed test of SPPB is recommended. Timed up and go test, TUG. This test measures the functional mobility of the patient. The patient is asked to sit in a chair of knee height, stand up, walk 3 meters up, turn around and walk back 3 meters, turn around and sit down again on the chair. The time taken is measured, which is normally 7 to 11 seconds. If the time taken exceeds 12 seconds, the patient is considered to be having impaired mobility. Longer the time, worse is the mobility, categorized as freely mobile, time 30 seconds. Gait speed. Here the patient is asked to walk a distance of 4 meters and it is timed. Any time greater than 5 seconds or 0.8 meters per second is considered abnormal and associated with increased fall risk. Balance test. Romberg test and functional reach test are commonly used tests to check the balance. Also with feet in 3 different positions side by side, semi-tandem, and tandem walk. Tests also screen the balance capacity of individuals. Hand functions. First pinch test, holding a paper or visiting card in a pinch and pulling this by examiner and assessing the strength. Second, hand grip and squeezing the examiner. Hand gives good idea about the hand muscle strength. Shoulder functions. Asking the patient to keep his both hands behind the head and then behind the back gives information about shoulder range of movement and strength of shoulder muscles. Referral to physiotherapy for detailed assessment is needed in patients with recurrent falls. Increased fall risk as assessed by the screening tests. In addition to detailed assessment, this will help them to receive strength and balance training. Advice regarding walking techniques, walking aids, confidence building, fall prevention techniques. Specialist referral for patients with neurological problems, orthopedic problems, Sensory problem. 2.5.4 Screening for memory and affective problems. For holistic health assessment, mental assessment is mandatory. Mental health is affected as the person ages. Mood and cognition assessment are two important components. 1. Assessment of cognitive functions. Loss of two or more cognitive functions defines dementia. Common causes are Alzheimer's disease and vascular dementia. Timely assessment and intervention helps in better management and slow progression of dementia. Rehabilitation. Intervention can also be planned in a better manner by timely recognition of the disease. Cognitive disability of a person usually remains unrecognized due to coping habits and gradual progression. Often a simple question like increasing forgetfulness in the last 12 months, particularly to daily life activities like using the phone, managing shopping lists, using money, managing medication, driving etc., helps in timely recognition of dementia and delirium. Delirium progresses fast in comparison to dementia. So recognized early and easily. Screening tools. A. Mini-cog. It consists of 3-word recall and a clock drawing task. In recall, 1 point is given for each correct word recalled. In clock drawing, correct numbering has 1 point, and correct positioning of pointing carry another point. Total score is 5. A cut-off point